We just heard a wonderful talk. In the last 2 decades, therapeutic armamentarium for diabetes has taken a complete U-turn. For the first 2 decades of my endocrine practice, as my young friend very aptly said, managing diabetes was the focus, and which then was not optimally done. Today is not optimally done. It did not happen then. It is not happening now, which I will show you today. But in the last 2 decades, first, gliptins took over in the first decade of this century, and we became very happy that we have drugs that do not cause hypoglycemia, because we had been petrified by prolonged hypoglycemia that we were seeing with drugs like chlorpropamide, glibenclamide. And even when gliptins came to the fore, sulfonylureas did not vanish. Still, glimepiride is there. Then in the last decade and a half, second decade of this century, we had SGLT2 inhibitors. Tell you very honestly, I was asked to give a talk about what is happening new in diabetes field in 2011 by Endocrine Society of India. We had a meeting in Pune. I vehemently went against SGLT2 inhibitors. And there's a reason for that, which I'll tell you down the line. And today, you see, I'm a converted soul, as most of us are. And this decade belongs to GLP-1 receptor agonists. We're talking about it. Now, just because GLP-1 receptor agonists are making so much noise globally, locally, have SGL2 inhibitors and DPP4 inhibitors become irrelevant or less relevant? The answer is no. As I was telling you, however, we malign pioglitazone, it did not vanish. We resurrected it again because it has its own role. As you see, this fundamentally is a session sponsored by Boehringer Ingelheim. So that is an admission. So we will be fundamentally talking about empagliflozin and linagliptin, but we have nothing against other glyphosins. They are also amazing drugs, but the session is about them today. All of you must know, much before the SGL2 inhibitors and gliptins, GLP-1 receptors came to the market. How many of you know that? First came GLP-1 receptor agonists, then came gliptins, then came SGLT inhibitors. Axenatide was marketed much ahead of, a decade ahead of SGLT2 inhibitors. But that is a story for some other day, not today. Now, if you look at this case, if we look at this relative, it's a young man today. Even today, young age has been extended to 60, and there's a new definition of the old age. When I became an endocrinologist, data shows that diabetes used to occur on an average at the age of 48 in India, and life expectancy was 54 years. All my teachers in the medical college retired at 52 years, 54 years. And today, the data shows the average new onset diabetes is 29 years. 1/4 of them develop diabetes before 25th birthday. And the life expectancy for that population is supposed to be 70 to 75 years. So it's not only that more people are getting diabetes, but people are getting exposed to dysglycemia for a much longer time that they used to. From half a decade to half a century now. That's why it's important to prevent those complications. So that's why it's a relatively young man having type 2 diabetes, hypertension, dyslipidemia. Now, probably, nobody would notice, he's that fat. I'm so like usually we attribute obesity to a guy who has that BMI of 35 or 40, Humpty Dumpty, 100 kilo guys. But we never associate obesity with a guy who's 78 and 5 feet 3 inches. So we never think he is thick. And xanthelasmas, again, as my friend Samrat was just now telling us that we have moved quite a little. This will probably prognosticate more about his potential morbidity and mortality and HbA1c. In my younger days, I thought it was okay because we never did HbA1c, it wasn't known. When we got the first apparatus of a continuous glucose monitor and hemoglobin A1C apparatus, it was so big. We imported from Kyoto, Japan in 1986. It costed $2 million then, and our director said, "You are making an institute bankrupt." But more importantly, it needed a room to occupy it. And they're like, difficult. So they, and fatty liver. For a long time, when first these ultrasounds came, when I did my postdoctoral studies, there were no ultrasounds. When my DM examination was round the corner, our HOD of radiology had retired, Professor Sodi Saab in PGI. And somebody told me there's a new machine which is around, which he has got in his private clinic. And I went to just have a darshan of that so that there might be a short note in my DM examination. If you look at it, what are the priorities that we have to set in for? Whatever you do, gliptins, SGLT2 inhibitors, amazing drugs, GLP-1 receptor agonists, dual agonists, triple agonists, there is no escape from. This is the most important determinant of health. And achieving optimal whatever you do, organ protection cannot happen. What Samrat was telling you, protecting kidneys. You don't expect protection of the kidneys when HbA1c is 10. You don't expect endothelial function to be normal and longevity of hemoglobin A1c is 11. It just doesn't happen. So lifestyle becomes primary. Uh, no, smoking is so common, obesity is so common. So diet management, people need to take diet because they are hungry. It needs to be taken. But today, the basic norm globally is we take food because food is available. It's not that we need food. Food is available. वहाँ सामने पड़ा है वहाँ पर अरे चाय समोसे दो चार उठा के जाएंगे. So those things need to be curtailed and talked about. A more holistic management, lipids, glycemic control, and probably LDL will prognosticate more longevity even in CKD uh, than diabetes management. Now, if you look, whatever that ominous octet, dirty dozen, sweet 16, every mechanism postulated, if you take glyphosine and gliptin and metformin to it, all these 8 mechanisms would be taken care of. I will not go to individually about them, but this combination would take most care of them. And just because we are looking at empagliflozin and lina combination, see this consistent drop in hemoglobin A1c right from the word go, and it is sustained for a long time. And more importantly, glyphosins do not put pressure on the beta cells because it's independent of beta cells, but in fact might even revive some of those cells which are stunted, which are likely to get apoptotic but are still alive. Now, evolving over the last decades, first look at I must have gone throughout this country for a decade telling people fix fasting first. I created that term when Sanofi started marketing Lantus because that's the only thing that could be done. But then we started looking at HbA1cs. But now we are looking at the amount of time that you are living in a normal metabolic glycemic milieu. And you can see it every time you goes up. A good chunk of time you spend time in range. So that again, whenever your blood sugar is in that time range, it does not cause the endothelial dysfunction. It does not damage the glomerulus. It does not damage your retina. Now, this is amazing. This is a data that's relevant. See, low blood, just in 2 days, it's empagliflozin study. It just starts dropping down immediately. 2 days, 4 days. C-peptide. C-peptide increase means now glucotoxicity has started going down and it happens so quickly. Now, glucotoxicity is not only that glucotoxicity as a concept. So long as your endogenous beta cells survive, whatever amount of that survives, magic is possible. All of you must have seen we delay the use of insulin in our own patients or because of whatever social reluctance, but I would say equally professional reluctance. जल्दी जल्दी में नुस्खा लिखने में in that process of turning over the people rather than taking care. The moment you start insulin late and beta cell It's completely lost. It's literally impossible to give an excellent control. It becomes like type 1 diabetes. You must have seen those MSI therapies, hyper. 3 बार रेगुलर इंसुलिन कभी 1 बार रेगुलर इंसुलिन कभी 2 बार भी लॉन्ग एक्टिंग इंसुलिन. And it's because that beta cell is not completely knocked out. So beta cell is like myocyte, a very sacred cell from the metabolic point of view. We need to protect it. You can say it just starts going up. It means that you're giving longevity to whatever beta cells still have not died, have not undergone apoptosis. And that's amazing. Now, again, glimepiride is one of the best sulfonylureas today, along with glipizide. No, we're not comparing it with glimepiride or hypoglycemia minimal. We've always been scared of hypoglycemia in endocrine practice. And then again, linagliptin. I was just now telling them, I remember the day when we launched linagliptin in India first time. It was an amazing day. Drop in hemoglobin A1C, fasting, PEEP. This is global data. Sometime we discuss. Indian data is even better on gliptins, and there's a reason for that. Again, to look at it, risk of moderate severe hypoglycemia. It's a huge difference. Because you know why hypoglycemia? Today, in the Western world, hypoglycemia is the third important cause of hospitalization and emergency, and it costs a ton of money. Now, second thing is obesity is worsening globally. We call it a dysfunctional fat. Someday we'll discuss that blood pressures, lipids, and improving insulin sensitivity and beta cells in our own patient becomes important. This is one of the first papers published from India more than 2 decades back. That when I realized that, in my whole MBBS, MD, DM class, we never had a Humpty Dumpty 80, 90 kilo guy. I haven't seen one in my. But today, every second kid in the matriculation is a 80 kilo guy. This is the first time I realized that obesity is striking and obesity is striking rather bigger way in women. First paper. And then we confirm it in a different population. We confirm it in 3 populations. First in 40 and above, then 20 and 40, then 5 and 50. I say, no, even children are getting thicker. And that will have a much longer consequence. And then, there is a global group known as Non-Communicable Diseases Collaboration Group. And we have been a part of this group for the last 2 decades. Looks at how non-communicable diseases are going globally. And we have a huge data from our own country, from our own centers. And this is a paper that we published in Lancet in 2016. Today, you see now India here being at, in 1975, a small nation like Ukraine had more obese people than India. Can you beat it? And that time we were still the second most populous nation on this planet, right? Fifth highest obese men. And low below, after China and United States, we have the third highest population of obese women. And many times we sort of underestimate it. These empagliflozin has shown some study loss in many times, when we compare it with gliptins, maybe it does not cause such a mammoth loss. But as I was telling you, in our country, people are not like 100 kilos, everyone. We are centrally obese and we have obesity at the weight of 78. If we lose 5 kilos, we come into the normal BMI because our height is on the lower side. So these few kilos make a difference to us. Under, I saw a guy, a young Kashmiri boy who flew from Bangalore to see me last May. That some new drug has come for obesity. 37 years old, 138 kilos, 6 feet 2 inches. This boy was conceived after I treated her mother for a pituitary tumor in 1987, parolcinomas. So that sort of a guy needs a. He lost 30 kilos in the last 8, 9 months. But we are not talking about that sort of an obesity in our clinic every day. Those few kilos are going to make huge difference. This another study, one of our own boys, Shafiq Kuche, who did his DM with us, saying that liver fat going down with. In my younger days, whenever somebody would say, इसमें sir fatty liver है, I would say, fatty liver तो हर abdomen में बाहर से भी fatty liver है, तो आप liver में भी होगा ना ये. But now today I know it's different. Today I know it has a pathological significance. And there's already, some one of our colleagues saying the drop in the blood pressures. So whatever, There's a data available today. If you have a resistant hypertension, if you are on 3 drugs, many people's hypertension would be smoothed out if you give them SGLT2 inhibitors. But if somebody is on a diuretic, we might need to change the dose of the diuretic or stop it. Because when you're talking about those 5 millimeters, 8 millimeters, it doesn't mean that everybody would get 5 millimeters, 8 millimeters. Somebody would get more, somebody would lesser. And those who would get 10, 15 millimeters drop, they might need a change in the concomitant hypertensive medication that you and me are giving them. Then the most important thing is preventing macro and microvascular complications, as my friend already alluded to. You won't believe it. When I'm talking about this Amperag, I was present there in Stockholm when this data was published. Many people were stunned. Is it true that in people who have a coronary event, who are on full statins, you can still cause a 38% reduction in outcomes in months and years to come? And I must tell you, there was a belief in my younger days when I was a postgraduate that coronary artery disease word was not there. We used to call it ischemic heart disease. And people used to say, and there was a MMS Ahuja, all of you know, he was a professor of medicine for 20 years before he, that's in itself a story he told me, before he went to endocrinology. He'd written a 3-volume textbook of medicine, which said that Indian population is genetically protected from ischemic heart disease. I wish the fellow was alive today. And this reduction, amazing. And again, the events, again, already elaborated. This data already shown about right from the Credence trial, DAPA-CKD and AMPA-kidney. All trials were truncated midway because the benefit was huge. All three. It started with Credence, then with AMPA-CKD. So, in the middle of the trial, the data monitoring committee decided that it is unethical if we do not give the benefit of the drug to that group which is undergoing placebo because benefit was huge. And that benefit is what was already alluded. Imagine a guy who is 60 ml. You prevent a need for dialysis or renal replacement by 20 years. I'm saying, what will do? Imagine that happening. There will be caveats. There will be people who will have problems. Penicillin has saved 1 billion guys, but it has killed also 1 million guys. But the point to do is save 1 billion guys or avoid killing the 1 million guys. That happens everywhere. And it is amazing. This happened. I was doing a nephrology rounds the day before yesterday in Srinagar with nephrologists. I said, "No, this is the most amazing time for a nephrologist for the first time, and that so many things are happening. This is the data this is a 10 years mortality, the first data from South Asia anywhere. Mortality data of 10 years. First time we realized even in diabetics, the most important cause of death is infections. We don't treat it well. And the most important diabetes related complication that kills people in this part of the world is renal failure. Published data. We did another study prospectively for another 10 years. Mohan was asked to write an editorial on this work by Postgraduate Medical Journal. People were now living longer. The gap between a diabetic and non-diabetic population was shrinking, but renal failure was still there, the most common micro and macrovascular complication. That's why it becomes important that and this slide, was amply shown now. See, Ampereg, all the round benefits, but kidney benefits round the clock, heart failure benefits round the clock. So people today, by regulation, cannot be deprived of that benefit of a great drug. Again, we are not taking GLP-1s cannot be taken. So the juggernaut is around. But I was telling you, we have a malnutrition related diabetes also. We are the epicenter of that. So we treat that also. GLP-1 would not be for that. But there'll be a huge class of people who today would benefit by a combination of an empagliflozin and linagliptin. Again, it's the same data. I don't need to recapitulate in terms of time. But today, if you look at the regulations, everybody say after SGLT2 inhibitors, if you want to protect heart, if you want to protect kidney, if you have potentiality of heart failure, This is the drug that would salve. Yeah, but if exclusively and obesity is an issue, dysfunctional fat is an issue, then yes, we'll have to look around on a different areas. So if you look at ease of use, just pop in a pill in the morning or in the afternoon, and this combination would be amazing. And many people would be benefiting. We should not deprive them of all that. And all of us know when you combine these drugs, even the urinary infections become much lesser. Linagliptin, we know whatever the complication, renal, hepatic, will take care of that. So in this particular patient, you can see now what do you expect that is it? Glycemia better, right? Starts in the 1 day. Abdominal fat getting reduced, glucose disposition index improving, and target organ damage would be potentially lesser, and beta cell function. This is the data that we published last year that non-communicable disease collaboration group, 13th of November 2024 on the Lancet published it on the eve of World Diabetes Day. And there's something amazing lessons for us. When we first started talking about diabetes was mid 90s, Manoj. Because that till that time, iodine deficiency, PCOD, pituitary tumors, adrenal lesions, uh, incipient, undiagnosed hyperparathyroidism. First time, and we thought 1 in 10 diabetics was in Indian. Then I was asked to do a workup on the economy of diabetes in 97. I said 1 in 8 is an Indian. When I left Sikkim, so 1 in 6 is an Indian. This data shows we are twice as bad as in-lab study shows, where twice situation is as bad as twice. Every fourth diabetic belongs to us, and more importantly, so, even in the Western world, this is United States, from 90 onwards, care has improved. But this is us, even though it's much better. 78% still defy a reasonable control of diabetes. We conducted a national study for 3 years, landmark study, and that data we have picked up from there. So yes, we have a huge prevalence from data today. When I talk about when I became a postgraduate, 1 crore diabetics. When I became a professor of endocrinology, less than 2 crore. When I left Sikkim, 6 crore. When COVID set in, 8 crore. When COVID finished, 10 crore. And this shows it is 20 crore. And disease awareness is low, and the common man is getting a very diverse information from different sources and is confusing him about the management. But great and cheap management is now available, and it should be availed. Thank you so much.